Well, good afternoon, everyone. Thank you all, first of all, for what you do and the services you provide to our communities. Thank you to a lot of you who have been incredible resources to me over the years to understand the issues of the delivery of health care, delivery of pharmaceuticals, delivery of dental care, all of the things that go together of taking care of our folks, and for taking time to come today to join Dan Feehan and myself. We've been saying that now during campaigns when people get really tired of them, there's a positive side to these if they're done right. They have the capacity to use the campaigns as a platform in a nonpartisan way to lift up the issues and listen to folks while the public's listening and help us understand what we need to do, whether it be policy changes, building coalitions, changing regulations, whatever that myriad of issues might be. You know what they are, and we have now, when people are listening, convened several of these. This is special to me in New Ulm because I started when we were doing Heart of New Ulm and some of the other things early on in my time as a member of Congress. Found really insightful solutions, answers, and providers over here. And this unique nature of delivering rural health care is something we really need to get our minds wrapped around. Dan and I have spent today, and he'll tell a little bit about it, a meeting with families, farm families, and the issue, of course, that comes up with farm families. Yes, they'll talk about tariffs, they'll talk about the farm bill, but you're not talking to them very long before they're talking about health care really fast and really concerned. And so none of this is new to all of you, but I am convinced those solutions are out there. There's things that we're going to need to do at the state level, should I be given the privilege to do that. And something I've learned, and Dan Feehan knows well, is the partners in the federal government certainly sitting in the location where we're at. Thank you for hosting us. We're really grateful here to be here. Medicaid, Medicare, and those issues that are never too far from anything that we do on reimbursement. So we're really grateful for that. So I think what we'll do is I'll have Dan just a brief introduction. Many of you, if you have not got the chance to know Dan Feehan, you soon will. And we'll just brief introduction. Then I think we've got just some things we'd like to try and get from you, just a couple questions. I think we gave you a heads up of what we're asking, then maybe just go around and maybe to save time on introduction and answer some of these questions at the same time, if at all possible. But Dan?
Yeah, appreciate it. And again, my name is Dan Feehan. If I didn't get a chance to say hi back there, running for Congress to succeed this guy, and hoping to make sure that the partnerships he's built over the last 12 years are allowed to continue. As you got to hit the ground running. There's no time because, from my own viewpoint, inaction is what causes the most harm in politics. My own career and background: I live in North Mankato. I grew up in Red Wing, and I've been in public service my whole life. I was a soldier, 2 combat tours in Iraq. I was a middle school teacher after that, which, you know, soldiers versus middle school teachers is a worthwhile discussion to have. But I learned a lot about it, and that's what I want to bring to you today. When you are on the ground executing policy, it's a matter of life and death. That's what it is in some way, shape, or form. And so the perspective you have there is the perspective that I want to make sure I still continue to know. Because I have a very simple philosophy of leadership along the way. Either a leader knows what they're talking about, or they know where to turn to when they don't. You can't make it up. There's not a third way. There's not a third option. And so that's this partnership that Tim has had with you guys is one I want to continue because I want to know where to turn to when we are making the changes we need to. Because to me, a year on the campaign trail has told me that in rural healthcare in particular, the status quo isn't working. Yet at the same time, the argument of moving backwards in certain ways is not an option either. And so it's figuring out how we can make sure we know what is working right now to keep it, but to keep progress moving forward so that we can deliver affordable health care to anyone, however old you are, whatever state of health you're in, and we can do it in rural communities especially, because that's our unique challenge. But thank you for being here, and here to listen.
Well, each of you, you were asked to be here, generously gave of your time because of your expertise, because of my office of understanding. We've worked, again, as Dan was saying, we have developed partnerships, many of us, or your reputations for what you've been able to do. I think there's much to be done here. I think, once again, it's going to be incumbent on Minnesota to lead on this issue. I think it's going to be very challenging federally to move anything, at least in the short run. But there's things that Minnesota can do, and we're here to hear from you. And I think what I'd like, if we don't mind, just tell us a little bit about who you are, what your representing group is, and then, again, in any order you wish to do this, just maybe thinking challenges, things that are working, things that we can do in both St. Paul and DC to strengthen rural health care, things that we should stop doing or change immediately to help you deliver that, and any other pressing issues. And I think what we'll do is, if it's possible, just spend a few minutes, maybe 5, 7 minutes or so on each one, to give us the idea from your perspective, from on the ground, what that means. And I think when we hear all of this together, you're going to see that unique picture of delivery of services and how it's done. So let's kick it off.
You see, I sat in the wrong spot. So thank you. My name is Tim Gallagher. I am a pharmacist. I've been a pharmacist for 33 years now. I'll try to answer the questions that you had. You know, for me, the what's working question is the easy one. There's not much working well for independent pharmacy right now. So I work for a company called A-Strup Drug, based out of Boston, Minnesota. We have 22 pharmacies in southern Minnesota and northern Iowa. Been in business since 1952, so we're not new in the business. But I can tell you that the last 2 years have been the most difficult years financially for our company ever. In large part to the advent of Medicare Part D. Both kind of a blessing and a curse. We had more patients now who have access to prescription drug coverage, but the reimbursements just continue to decline. The networks continue to get restricted, and the DIR fees, it gets a little technical, but direct and indirect remuneration is a term that's allowed under the contracts, and some of the plans just continue to pull back money from us. We don't even know when we process a claim what we're going to get paid. So we may adjudicate a claim and may say we're going to get $100, and sometime between the next 3 to 6 months, one of the plans may pull back $20 from us. So we don't even know if we're going to make money or not. But then that's a federal issue. On the state level, I'll say that it continues to be a challenge in terms of both network access and reimbursement. We just closed a pharmacy in Albert Lea, Minnesota that's been there for, I don't know, 50 years or something. And we don't typically close pharmacies. I mean, we're the company that will keep a pharmacy open in a small town just because they need pharmacy services. We have a pharmacy in Adrian, Minnesota that's got 900 people. We have a pharmacy in Harmony that's got about 1,000 people. They're not making money, but we kept them open because they had pharmacies for like 150 years. So if we leave, there'll be a gap there because nobody else is going to move into those towns. The biggest challenge for us is the consolidation in the industry and the vertical integration with the pharmacy benefit managers. When you look at things like the CVS Aetna merger and the Cigna Express Script merger and things like that, when you look at a model where a company not only has the largest number of pharmacies in the country, about 10,000 retail pharmacies, CVS, the largest long-term care pharmacy in the country, and the largest specialty pharmacy, $35 billion a year in specialty sales for CVS. If CVS specialty alone was a country, their GDP, $35 billion, they'd be the 100th largest country in the world. And will they let a little guy like me? I operate a specialty pharmacy out of Mendota Heights. That's what we do. Specialty pharmacies are really expensive drugs. 80% of the new drugs are specialty. They won't even let me in their network. And so, you know, that's my challenge: access, reimbursement. And I'm not here just to complain. So, some solutions, right? Pharmacy benefit managers are not regulated really very much at all, if at all. So in Minnesota, we would encourage, if you become governor, to help us to get the pharmacy benefit managers licensed. The National Council of Insurance Legislators has draft language to have them licensed with the insurance commissioner so they can regulate them and control them. That would be one thing we could do. I would encourage you to look at what Ohio did recently in the managed care Medicaid program. They did an audit and found out that there was a huge spread between what pharmacies were getting paid and what the state was getting billed. And furthermore, they found out that CVS was paying their own pharmacies on average about $9 a prescription more than they were paying the independent pharmacies. If they can't buy you, they'll squeeze you until they run you out of business. So again, I think there needs to be more equity in the managed care Medicaid market. I'd like to see Minnesota become an any-willing provider state. It is an any-willing provider state for a lot of medical services, but not for pharmacy. Pharmacy's carved out. I'd like to get pharmacy in there so that if we're willing to accept the contracts that they offer us, then we should be able to get in there. And then I'd like to see Minnesota become a brick and mortar state for Medicaid. Right now, all our Medicaid specialty prescriptions are sent out of state. So think about this, the tax dollars that I spend help support Medicaid, it's federal and state, but the state tax dollars go to send prescriptions to Orlando, Florida, to Las Vegas, Nevada.
Why did they do that?
Well, ask them. It could be because there's no corporate income tax. It could be because they don't have to pay the 2% provider tax. I don't really know, but I know we're the only independent specialty pharmacy in the state of Minnesota. We could have built our specialty pharmacy in Orlando like everybody else, but we wanted to keep our money in the state, keep the jobs here. But I can name a handful of others that haven't done that. So, but I don't really know the reason for sure. So there is many states have brick and mortar laws that say that if you're going to fill a prescription for a state's Medicaid patient, you have to have a physical pharmacy in that state. We just recently got licensed in Georgia, ran across in Georgia. I can't fill prescriptions for Georgia Medicaid patients. So, why should the pharmacies in Minnesota send all these out of state stuff? Brick and mortar. And then finally, the call it what you want, the provider tax, the wholesale drug distributor tax, the Medicare tax. It puts every healthcare provider in Minnesota at a competitive disadvantage with the surrounding states. And in my business in specialty pharmacy, my gross profit margins run about 4%, between 3 and 4%, not net, gross. So if I pay 2%, you're wiping out half my gross profit. And it really needs to expire. And I know we keep talking about it, it keeps in the sunset, and then they keep extending it. So
How do we keep 100,000 people on Minnesota care?
how do we keep them on?
Without the provider?
Well, I'm not sure. I'd like somebody to explain to me why we need it, right? With all the other plans we have. We already have medical assistants, we have expanded medical assistants, we have all these other things. To me, I really wonder if it's necessary. Maybe I just need to be educated. But I can tell you that it's hurting us. And the other thing is, even when we pay it, so we pay it for all the drugs that we buy, even when we ship out of state, we have to submit a refund, and the state holds our money for the year. We can only submit a refund once a year. At least if we become governor, maybe we could talk to the Department of Revenue that we can file a quarterly. Anyway, that's kind of the gist of my issues primarily, but I can tell you that if you want to keep pharmacies in rural Minnesota, we have to make some changes, because frankly, they continue to disappear. And if we want every prescription to be shipped from some large mail order pharmacy or Orlando, we're headed in the right direction. Thanks for listening.
Thank you. Well, I'm Dr. Flynn. I'm a dentist out in Lewiston. I'm a prescriber to his pharmacy in Harmony. Okay? Because I treat patients from Houston, Fillmore, all the way to Moore, all the way up to Goodhue, Bobshop, a lot of from Olmsted County to come because of the difficulty in getting in. So as far as I know, I'm the largest private provider of state programs in my region. Okay? So I've been there, I've done that, I walked the walk, and I'll try to talk the talk here today. And I will come back to that provider tax issue that you brought up, maybe offer some insight. I do want to brag about a couple things, though. We're not here to hear all the negativity, I don't think. I don't know if most of you know this, and Emily Piper, the Commissioner of the Department of Revenue, I spoke to her this morning, and I was at a summit. Minnesota ranks #1 in oral health care in the nation. So kudos to the dentist. We're #1. That's phenomenal, isn't it? So we're doing our job. In fact, in certain programs, we rank very high compared to the rest of the nation. But let's talk about where we lack. We're well below average for our state programs underprivileged. We're at about 42 to 38, depending on if you're talking fee-for-service or the health maintenance organizations. That has dropped every year since 2010. So we don't have a good track record, and most of you know CMS is going to get another case about that. And rightfully so. We should do a better job. We can do a better job. We're ranked #1. In general, we got to bring our programs up. So I'll talk about a few issues that are causing that problem that are running way under 50% as far as patients seeing a dentist in a given year. And I was citing children. Adults is even less, is 138. One is our low reimbursement. Again, you heard the pharmacy part, but for decades as a provider, we've been abandoned, so to speak. So we rank last in the nation when you factor in the provider tax. We're 49, but if you take out the provider tax, we're last.
Where's all the money going in healthcare then?
And
We're spending twice as much as
in my
anybody else.
opinion, and here's where we might find a solution to your provider tax, we're giving a lot of money to the third-party HMOs and other places that did get a double in capitation. But we as professionals are still working on a 1989 fee schedule basis. We've had a few increases. And that's the year my daughter was born, that's why I remember it. She's a physician assistant now over in Madison, Wisconsin, almost 30 years ago. So we were missing it by 3 decades. And so we've ignored this problem, it keeps coming to the forefront. And I've been criticized for talking about money. Okay, there's no shame in talking about it. This facility did not get built without money. My dental office will not get built without money. I will not have staff, and I can't do it because my reimbursement is 31% usual and customary. 31%. That's way under what it takes, so we're actually subsidized. I just told you 50% of my base is state programs. How can I possibly expect to make things work for the other 50%? And it's not the only areas we donate. Some of the areas that we need to. I'm gonna give some more kudos to the dentists. Say we're not participating. 60% of the dental providers are signed up for the state programs. 63%. National average is 20%. You got 63% signing up to help these programs with the worst reimbursement in the nation. We are Minnesota nice. We are flat out Minnesota nice. We've done our job. All we need is the right tools to get the job done. If we're given the right tools, which in my opinion, if we hit median of usual and customary in the nation, the dentists of Minnesota will rise up and take care of this. I also don't believe that it's a diversity or a bias or this and that. We all know there's many barriers to care, but let's not lose focus of the primary problem. We cannot run a business without the right cash flow. There's no question about it. I have talented staff, but they will leave and go to other areas if I can't get them. So administratively, it's complex. Our barriers are not overcomable. We can do it. But getting back to the provider tax, I think that it's not a broad enough base to collect the money that we need. We need to go back to these providers that are getting all this money. We need to put a tax perhaps on the insurance and the third-party administrators up front so it goes through the whole base. It doesn't become a sick tax. We're taxing people that need care. That's not the way to do it. So we need a broader based tax with some focus on what you need to solve, in my case, the dental issues. And right now, our budget is very, very low. In fact, it's hard to ascertain what it really costs because I can't think of one of the third-party administrators that will truthfully tell me what they're spending on dentistry. Let's say it's proprietarial and all this kind of stuff. You've heard it, haven't you? So it's hard to get to the bottom, but we've had the opportunity to fix the dental equation, but we've ignored it. Not because you didn't put enough money in. I believe you are putting enough money in, but it's still not trickling down. So with that, I'm gonna keep it brief because there's other people I need to talk to.
Okay, my name is Karen Brassi. I'm the Director of Nursing here at Oak Hills. I have been here 28 years. I started at the age of 16 years old as a nursing assistant and have worked my way up. Going through the nursing program, I've been a charge nurse, case manager, and now Director of Nursing. I'm very passionate about long-term care. I would say the most critical issue that we are having right now is the workforce and getting people to come and work for us for what we can pay. These people work very hard. Our elderly deserve it. I thought this was a really interesting fact. We have, there are more than 1,000 skilled, compassionate caregivers working in Minnesota to provide quality care and services and support for seniors, but they can't keep up with the demand. With nearly 3,000 open direct care positions, an average of 15% vacancy rate for nursing positions in senior care. Minnesota has caregiving crisis that needs to be addressed. Yet our elderly population is growing, our comorbidities of people are growing. What people want to treat nowadays is growing. They say the new residents in nursing homes now are in assisted livings compared to years ago. We have, the people that we have in nursing homes are very complex and require complex care. And in nursing homes, you have your nurses and you have your nursing assistants, and as nursing assistants, they can start at the age of 16. That requires a lot of training, a lot of commitment, a lot of compassion, a lot of dedication. It is a very tough job, yet these gals start at like $12.50 an hour, and they're taking care of people's personal needs. Mental illness is growing. In addition to the comorbidities, you're treating multiple diagnoses with, in addition, mental illness, both with residents and families. Sometimes it's not the residents that we're having difficulty with, but the demands of the family members. The demands and expectations of family members have really increased and is very time consuming for everybody involved. And it's just sad to me. These girls girls and gentlemen work very, very hard, and yet they can go to a fast food facility and make more money. It's hard to comprehend. So I'm just gonna speak on that for now, because Deb is also from Oak Hills, and I want her to go a little bit into she's our Medicare coordinator, and some of those concerns.
Yourself at 16 years old, what drew you to it? What spoke to you about it? How did you learn about it?
I started as a volunteer and started to desire the compassion for these elderly people. These are our grandmas and grandpas, our mothers and fathers. They've worked hard all of their lives. They deserve good care. There is lots to be learned from the elderly population. And the other piece of that I'm really passionate about is we need to get these young people in to take care of these elderly people. I find that if you do not get them in at a young age to take care of them, people are not interested in long-term care and nursing. It's very difficult for long-term care facilities to compete with the wages of nursing staff at hospitals. So we end up utilizing a lot of, well, I think we do very well here, but as soon as you have someone that's out or retired, it's difficult to hire a nurse to come on board. And so we end up utilizing pool services, which cost us thousands of dollars to have temporary staff come in. And with that, they're unfamiliar with your system. You can train them as best as you can, but they're here temporarily. They're not here. They're not in it to win it. They're just here to do their job and move along. The regulation changes that we've had, I mean, we've always had tight regulations, but now we've went under a phase 2 and a phase 3, and we're gonna go into a phase 3 here soon in 2019. And with that, there's a lot of training compliance. And so not only is this difficult work for these gals and gentlemen, there is a lot of training required. So it's a huge commitment at 16, while you're still in high school, to sign up for a job like this and have the type of training that is required, and then just being out there in the trenches is tough work. And the pay that they get for it, you will find that some don't feel that it's worth it.
Deb, you're gonna tell us about reimbursement on this.
I am. I just want to add, my name is Deb Webster. I work as the Medicare coordinator at Oak Hills Living Center. I've worked in long-term care since 1982. I just want to, in a variety of capacities, all different, I've worn a lot of hats over the years. I just wanted to add to Carmen's, I would love to see a partnership with the school systems to go back to the basics. We had trade schools that were through the high schools, getting back to taking care of people, as she said, getting these girls and gentlemen, girls and guys and gals, getting them reacquainted with taking care of basic needs, a partnership of doing cares or part of their classes here. I would also like to see the age restrictions for using mechanical lifts, ceiling lifts, and stands You have to be 18 years or older. It poses a huge problem on the afternoon and evening shifts. We may have one person over the age of 18 on that shift. The rest of them are under 18, and one gal literally has to accompany every lift and stand, transfer. It's a huge problem. I would like to see that regulation out the door. And I work in Medicare and insurance benefits, and I have a couple of things. Consolidated billing, when somebody comes into our facility under Medicare skilled benefit Part A, there's something called consolidated billing. The nursing facility is required by law to assume all costs associated with taking care of that resident during their skilled stay. I hate to admit that when our admissions crew sits down and looks at potential admissions, we actually look at sometimes not just the whole overall care we have to provide. It also includes the financial basis. Somebody who's on extensive chemotherapy or radiation, those costs exceed our reimbursement. So we're operating at a financial loss for some of our residents. And as Carmen said, the acuity is high, the expectations are high. The people that we're serving today are truly post-acute right out of the hospital, continuous care. Insurance reimbursement, managed care, not a fan. I totally agree with the philosophy. I think if somebody can be taken care of at a reduced level of care or a different service, by all means, we should implement that, and that should be practiced. However, when nobody really wants to come to a nursing home. If somebody comes here, they truly need 24-hour skilled care. And I'm really disappointed that our insurance companies dictate the amount of skilled services we could provide. I'm unfortunately the person that has to go knock on somebody's room door and say, "Hi, I'm Deb, and I'm just going to let you know that Aetna or Humana has not authorized any further care, and yes, I'm sorry you can't get in and out of bed or on and off the toilet yourself just yet after 5 days of therapy, but according to Aetna, they say you can. So I'm issuing a denial, and as of tomorrow, you're going to be private pay status, and the devastation and the financial impact on families. We're discharging residents home that should not be discharged at home, and they're going to end up being rehospitalized or injured or they're vulnerable. And for the people that end up staying.
Why do you think they make those decisions?
Why does managed care make those decisions? Financial reasons. So it's all about the.
We probably should be focusing on the medical reasons and the folks, the providers.
Right. It's been my experience, they're basing their length of authorizations based on diagnosis codes. I read
An average return
It's just a
to
running.
function. It's just
Correct.
average, but of course, everybody's individual.
Right.
So you do a one hip
Can I ask
replacement,
you
and
as-
that's one.
That's it.
As experts in this, how do you respond, and this is the state side, the federal side of this, on the regulations and listening and on that. How do you respond this year when we had the elder abuse crisis, if you will? And how do those situations happen, in your mind, when we saw this situation across the state?
How does elder abuse happen?
Yeah, and in Minnesota, why did it appear so prevalent that the consensus was from people that there wasn't enough eyes on this, there wasn't enough at certain facilities, long-term care, different than you, when you're providing that there's a different level of licensing, different level of requirements. What's happening out there as you see this? How does this happen?
When it comes to elder abuse, when you talk about licensing, there was a whole wave a couple of years where assisted livings popped up everywhere, and there was a variety of licensing you can obtain for different types of assisted living facilities. The less restrictions and regulations you have in place in a facility that takes care of vulnerable people, it just stands to reason that the risk for elder abuse, vulnerable adult issues.
Should those facilities
should
be
increased.
required to do the same things you do here in the protection?
I worked as an assisted living housing coordinator for several years, and I loved it. I understand why regulations are coming into place, but they're not staffed the same. I wore every cap of every department when I was housing manager. You have universal workers with different sets of skills and knowledge. I have pros and cons thoughts.
No, it's helpful, and I said I appreciate you, and this is no easy fix, and I'm not looking
It's
for
not an easy
that.
fix.
But I think as we talk about this, because there's gonna be a tendency, and one of the things is trying to fix the problem, we will tend to move towards regulation as a way of not out of malice or anything, but I wanna make sure if that's the case it goes, that it's actually doing it.
Right.
and working.
Because if you think about the people that are in assisted living, like I said earlier, those are the folks that I used to take
That's
care
correct.
of 15 or 20 years ago,
Changed.
Right.
under more stricter regulation, you know?
That's right.
So I think some regulation is warranted in assisted living, some more regulation. However, I do not think it should mirror what is currently in the nursing home industry.
Good.
So,
Well, thank you.
thank you.
My name's Scott Winchell, I'm a Brown County Commissioner, and I'm here, I think we're gonna at least start talking about what does work. But seriously, it needs your support, and that's county-based purchasing. County-based purchasing is the method of delivering Medicare, Medicaid, and Minnesota Care to people in need. County-based purchasing currently has about 25 counties that are in it, and another 10 that are applying through Prime West, which is another one of the county-based purchasing units. South Country Health Alliance is another, and Itasca Medical Care is the third. County-based purchasing is not your normal delivery of services. It is completely different. Although it does all of the basic things that the other services provide, it also supplies help in areas, and I'll give you a couple examples here. One of the programs that South Country Health Alliance offers in addition to their normal coverages is Healthy Pathways, which is an early intervention for people with mental health issues. And what it happens, currently South Country Health has about 120 people that have been in the program. But what it does is it helps people early on and divert them from continuing down the path that they're in. It reduces, from a county standpoint, and this is what's important to me, it reduces our levy expense because we don't have as many sheriff's office calls. I don't have as many mental health institutionalized stays that we're ended up paying on. Very good example of what's different about county-based purchasing versus the normal delivery. They offer healthcare coordinators at the hospitals who work with people who, for example, use the emergency room, overuse the emergency room, and so they begin to get them scheduled into regular care at the clinic where they should be going, or urgent care, or lower cost areas, which also, again, saves county money. They have community connectors who line up services that are members of either public health or family services divisions. And they work with people to see what kind of care might be needed in your situation. You've got a family and I might have multiple, I might have some mental health issues, I might have some chemical dependency issues, I've got these areas that need to be covered. And those people are specifically set there to get the people into the services that are appropriate and cost effective and effective in the delivery. What are some of the challenges to county-based purchasing?
Wendy, enter to the chapel, please. Wendy, enter to the chapel, please.
One of the issues he talked about was the withhold that the state does to the money that it should be processed through. The state for county-based purchasing withholds 8% of the money until the following year when they look and see if you've met the outcomes and you get back your percentage. That seems like a long time to have to wait to figure out if you meet the qualifications. But even more serious than that right now, I think, is in the past, in July, the state has been putting a delay on their payment. And so even though we are earned the money and deserve it of it, they do not make that payment, and they just say, well, we're just gonna hold it and you'll get it in 30 days from now. Well, guess what, our providers, a lot of them are very small. We're talking, we've got 4 counties in the northern section of Minnesota, might be 1 provider in the whole county, okay? So they need to operate on that capital. And now, next year, they're actually going to, in all 12 programs that we run, or 7 programs that we run, they're going to extend it to 2 months. So now we're supposed to float 2 months of the state's money. It can't happen, we can't keep doing that.
What's their reasoning?
Yeah, that's a good question.
Have they ever told you?
No, not that I'm aware. Have you any information in regards to that?
Basically, it shifts the cost into the next fiscal year, so they would pull payments in May and June. They hold all capitation payments in there.
So it's not statutory why they're doing
It is legislatively.
it? It is now.
They passed legislation shifting those payments into the next fiscal year, which gives them a bump this year because those payments aren't on this year's books. They push them off.
So they started, I believe it was back in about 2011. It started with just 1 month. So in non-budget years, it's 1 month. In budget years, it's usually 2 months.
No, next year it's gonna be 2 months. So not only does that, A, cause a problem, we've got to float that money over the providers, B, it costs us the interest on that money, $100,000.
And the state has done shifts like that over the years, and the biggest one was the schools under government funding, we have a huge shortfall. But the difference between that and what's happening here is that in subsequent years, the state bought back those shifts in education, so the school district.
So they haven't bought this one
They
back
haven't
yet?
bought this one back,
Okay.
so that's something that would be helpful to the state
Okay.
to step up and buy back those shifts and pay on a timely basis.
In the past, we had cost differentiations between northern counties and southern counties because of the extra costs that northern counties create in the rural setting, that you just have more costs there associated with that. And they've taken that out of the equation when they're setting rates. And so that really hurts us because when we're trying to provide benefits there, it's costing more money, but they don't realize how to recognize that. And so support in that area would be very helpful, that understanding that those northern counties are gonna need a higher reimbursement cost there. I don't know if have you got an example of what in county?
Yeah.
Commissioner, do you have a map of where those counties are that you can share with?
I do, whether, okay.
We've had these discussions on county-based purchasing. How is the state responding to you on county-based purchasing?
How does the state respond to us?
Yes.
Am I free to talk? Extremely poor.
Why do you think that is? This is the question I keep coming back to.
I'm not sure. You know, I've been in the county commissioner for 8 years and have experienced procurement procedures. They don't have this issue with all providers, but I'm on the board for South Country Health Alliance. For whatever reason, they seem to have it in their craw that they think we kicked them off someplace down the road. I don't know. If you talk to providers, and I encourage you to do that, go out and talk to the providers. They love us, absolutely love us. But when we come to the state, we're treated like the lost grandchild or lost stepchild. We just had negotiations this morning. I don't know if I can talk about that. No, cannot, okay. But it's a serious.
No, I'm familiar with this, and we're trying to figure out.
Yeah, we shouldn't have to be that way, you know? We're trying to do the right thing here. We're trying to increase the dollar and make it go further and everything, but we shouldn't have to battle our own state agency. That's tough.
All right, no, that's good, that's helpful.
Yeah, and just, I mean, I got public health and South Country Health Alliance hat, but the county-based purchasing sets a whole new flavor. When I came to Minnesota, I thought, what is this? I haven't worked in public health all my life in Minnesota, and I had to be convinced, but I am hook, line, and sinker on this one. We can provide a better service to our members, our providers are much happier, and we're saving dollars. We don't have a lot of those top-end administrative costs that those other MCOs do. And I know we're a nonprofit, I get that, in Minnesota, however, income can have a whole set of expenses to make
As you
that profit.
view this, is this more ideological than actual practical application of what we're trying to do with county-based purchasing? Is there just an ideological kind of resistance to this?
With the state,
Yeah.
with Department of Human Services, I think, for whatever reason, I just think they feel this affiliation with those bigger companies, with the Blues and with Health Partners, and I think that they have had a long-term relationship with them, and I think that seems to continue, and I think they feel like they have to be very, very fair to them. Which,
And anything new is a challenge.
anything new is a challenge. It does give us a little bit more control in our rural areas, and the metro doesn't have it, it's just in the rural communities. But we have example after example after example that this model is working for individuals and for our population. I mean, I can give you tons of examples of individual cases that we have made a huge difference in their life, and it's because the county-based purchasing program is in our county. We have a connector who gets the message from the hospital, who reaches out to public health and social services. We all work together and make a difference in those people's lives, and we keep them out of the nursing home for as long as we possibly can, so we cut those costs, and we keep them at home for as long as they possibly can, because we can cut those costs. And we reduce their trips to the emergency room. We reduced one family that was going at least 3 times a week down to twice a week because of that collaborating effort. So it is working. Public health hat on.
Yes.
Prevention, I think has to be a focus. I know we complain, we
Yes.
spend how much? 90% of our health dollars are on treatment.
That's correct.
10% is spent on prevention. 10% of someone's health is related to healthcare. 90% is related to social determinants
We
of
have
health.
to turn that up.
That
on
has
its
to be
head.
turned over.
Yeah.
And public health has the state, in my opinion, does not value public health infrastructure. A third of my budget is county tax levy, and the burden is a lot on the county tax levy. A third of my budget is mainly from federal and federal pass-through grants, and thank you, and continue that work. So thank you, and continue that work with the block grants,
That's
the
right.
block grants that need to happen for us. But the state, we have a local public health grant, which is supposed to be for public health infrastructure. It has not increased since 2003. So no, we haven't had a cut, but think about wages, think about expenses since 2003. So yes, we've had a cut. And it's.
Are you telling me that inflation should be figured into how we do budgets?
And that grant only covers 6% of my work from the state. So the state is giving me 6% of my work for the work that they mandate basically in 145A in the statute. So I'm advocating for all of the work that we do and the good things that are happening in Brown County, and I think you know that, you've seen this work. In our county, we collaborate so well together. Healthcare, community services, business owners, public health, social services. We work together to make it as most efficient, and we all take a part in it.
Yes.
So we've got Underage Substance Abuse Coalition. Again, that's coming, our funding is kind of coming to an end, and that is to prevent young people from starting to use chemicals. And I think you know there's an opioid crisis in the state, in the nation. We have a meth crisis here. ACEs, adverse childhood events. We've worked really hard to eliminate those. That's not going to happen, obviously. We're not reducing, for whatever reason, we're not able to reduce the adverse childhood events that happen with kids. But we can with public health, and we're doing this, or trying to do this. We need more infrastructure and support to do this, is teach resiliency to not only kids, but to families. How do you be resilient? Because the bad things are going to still happen. They're not going away. So how do we do that? Mental health, I think we all know how bad that is, and we are working very hard at trying to implement that on the preventative end. We can't always control some of the genetic, physiological, biological issues with mental health, some of the real serious things, but there's a lot. If you look at the statistics, and we're looking at that right now, even for Brown County, depression and anxiety are our largest mental health diagnoses. And those, it's not the schizophrenia, it's not the bipolar disease, it's just general depression and anxiety, and it's coming from stress and people not knowing how to be resilient. So we're working on that. We're trying to implement resiliency policies. So those are, and that is going well as far as our collaboration. But again, funding and public health infrastructure are not there to support it. And then there is infectious disease, which that comes out of that local public health grant that has not been increased since 2003. Tuberculosis. That doesn't, it's contagious. measles, all these outbreaks that we've had, we do not have anywhere near the public health infrastructure that we need. We have I can't give specifics, but we have a large outbreak in this region right now, or not a large outbreak, I should say. We have a situation in this region right now that we have staff in public health in this region and not in my county that have 700 contacts that they are trying to contact about a communicable disease. We don't have the infrastructure for that, and we don't have the funds. And as far as pay goes, I pay lower than the nursing homes, so you can imagine where I'm at compared to the nursing home, compared to the hospitals, because I don't have funding to pay. So to get nurses to work for me is extremely difficult. My workforce shortage is, sometimes I don't even get applicants at all for my openings, 0 applicants, and we have to advertise again. So things are working well, and so we need help from DC and from St. Paul.
It's a common theme with all of us. My name is Doug Yeager. I'm the CEO of Open Door Health Center, which is a local federally qualified health center here in the region. We are housed in Mankato, Minnesota, but we have served clients from over 55 different counties, and just recently expanded with the Jordan and the Clarkfield location for dental services. That is a continued increased need throughout the region here. I guess what I can say is, the staffing, the human resources part of it, along with wages, is I think our major issues as well. We are serving more and more clients every year. As an indication, in 2016 we served 8,000 people. Last year we served over 10,000 people, and as of yesterday we're already at 9,800 people that have been served through the services at our federally qualified health center. We do medical, dental, behavioral health, and try and do all the social determinants with our staffs as well. And we're really about filling the gaps. So it's important for me, as I'm running my organization, to help keep services local. And what I am seeing throughout the region, I'm getting calls on a daily, weekly, monthly basis from medical providers and dental providers who are closing their offices. And they can't find young dentists to come in or new physicians to come in, and so they're looking for my organization to keep those doors open. And right now what's hindering us is both the human resources side of it and the financial resources to take on those facilities to do that. But I'm passionate about trying to do that because there is a huge need here in these communities. You talk about the southern areas where your pharmacies are at. You just experienced the medical side closures in those communities. Where those people are going to go? They have to drive hundreds of miles. Right now they're driving hundreds of miles to come to my organization and to help them get the transportation dollars in order to be able to do that. And if we could keep them local, they can go back to work, they can be more productive within their communities instead of having to spend all those monies and those hours on the road going to a different place. And so those are the kind of things. Looking at the FQHCs throughout the state, there's 17 of us throughout the state. Most of them are in the Twin Cities. There's 3 north of the Twin Cities. There are 2.5, I guess you could say, here south of the cities. Open Door is the major one. South of the cities, there's a Migrant Health that has some offices in Rochester and Montana, in Wilmer. And then there's another partnership with an FQHC from South Dakota that's in Worthington, and they only provide medical. We provide it all and are really trying to take care of that whole health to improve those social determinants. We have the same problem. McDonald's is paying more than what we're paying, and we've had ads out for a year plus to get people to come, and my HR person is turning very white as her stress level has gone up. She's like, we've got 15 positions open in our small facility, and that's outrageous. It's care that we could be serving people.
What ideas are you hearing that you think will improve our healthcare system? During a campaign, I'm hearing all this, all we have to do is do across state line sale of insurance, it'll work itself out.
I'm not so sure that that's it. You know, investment, of course, in where those dollars are gonna come from, I don't have this. I really don't. But
Is it safe to say, like we said, the prevention piece of this, if we really start
Yep.
focusing on the front end, we have dollars to save?
I truly believe that. You know, like what we're doing more of the preventative stuff, trying to keep people out of the hospitals, trying to keep them out of the nursing homes. If we can take care of this stuff more on the front line, the better off we are. Medicaid patients, as we know, typically go to the ER. If we can keep them out of that ER, go to the primary care physician, their treatment is so much better taken care of, and those healthcare costs are dramatically less. So the investment in the primary care sector is probably where it's at, you know, to keep those social determinants, to help keep those at that preventative level versus the specialty level, because people have waited so long to get that care. If we can take care of it more at the front end, the better off, I think, we as a society.
Okay, I'm Keith Stelter, and I'm a family physician. I'm the Associate Director of the Mankato Family Medicine Residency Program. And just recently, I serve now as the President-elect of the Minnesota Medical Association. And I guess I'd second a lot of the things that were said around the room here. I guess I could start off by saying what I think is working well, and that dovetails with some things that were said here. I think, and I'm faculty in the Rural Physician Associate Program. This is third-year medical students. Actually, there's one coming here in New Ulm. We've got 40 of them all over the state. We've got them in the Metro Path in the underserved areas. That program has to grow. That should be in every medical school. Mayo should have their own program. We should have probably 100 students.
We were up in Duluth with students from that program.
Yeah, so that's what's working well. There was another thing that's working well is Dr. Jeff Schiff at DHS. He recently, we talked about opioid abuse. He actually removed the prior authorization for Suboxone so that I could write a script for it. Once I've gotten my license, I have my DEAX number. I could write a prescription. They could go to the pharmacy and not wait a week to get their Suboxone to be treated for their opioid addiction. If you wait a week on an opioid addict, they're just going to start to use again, and your prescription is lost somewhere.
And the last one were our folks on medical assistance who got rid of the pre-authorization, right? That's what we did.
Yeah, so that was actually a great move in his part. I would ask that more prior authorizations be eliminated. The amount of time that I spend kind of flicking through my Epic EHR looking for the right antihypertensive drug to be treated is ludicrous, and then I send it to the pharmacy only to find out, oh, that's on another tier copay, and can you change it? I'm like, sure, but I have a line of patients that I'm trying to see, and so they put these modern day speed bumps in is kind of how I kind of consider that. I think it's paramount for primary care to partner closely with public health. I think that's where the real juice is going to be made. We have to even co-locate ourselves. We've got to work more collaboratively together on prevention. And there are some exciting things that we could do if we had the right funding. Some seed money to get those offices started. As a primary care physician and working in a system, if I go and say, well, I want to hire this or that, and they're like, well, the system's working good enough. We're just, we're still making money doing our hip replacements and stuff like that. And so it doesn't rise to the level of, the CEO of the health system to kind of say, yeah, we're going to put our money into having an office with a public health nurse or a community aid worker or a community health worker that collaborates with a family physician. So I think that's kind of one of the things that this state could do that would be very innovative and really move the needle on prevention. I can tell you in my office, one of the things that was transformative is when we housed a social worker in my office. And all I had to do was walk down like 3 doors and talk to a social worker, because I'm sitting here writing a prescription for insulin, which, by the way, the cost of that has gone astronomical. That's another issue, and they said, but Dr. Stelter, I'm living in my car, and I just got kicked out of my apartment. And I'd be like, okay, game over, you know, I mean, what are we talking?
I'll take it a step next further. If that collaboration was also happening in the full-service community school, the children are being taken care of simultaneously.
Right.
And now we're starting to hit all those problems because kids don't come in pieces, and those families are that way. Because that's what, while that's going on with the parent,
Right.
we're trying to figure out how to get the kid into class on the next day. All of those different pieces make it difficult to attack the root cause.
The root cause,
Yes.
right, yeah. And so there, you know, there are some, we have to kind of, we can break down some barriers, we gotta work across lines. You know, anxiety and depression, they're very prevalent, but they are actually 2 of the most treatable health conditions that we have. We're maybe okay with schizophrenia, you know, but that's highly complex, you know, that's like treating like really hard cancer. I mean, anxiety and depression, that can be very bad for people, but if you get it off the bat, that's like treating a sore throat. And so we can do that if we have the right supports. I think one of the ways to do that, the state could do as well, is more telehealth and you know, broadband access to kind of take away some of that windshield time that's going on, and have our clinical psychologists be able to meet with students and even adults in their home for a 15-minute visit to do some cognitive behavioral therapy. That's all some people need, is just a check-in to kind of like keep them on the rope, you know, keep them hanging on to their rope, that's their lifeline, you know. And so if we say, well, you know, you gotta come to an appointment like 2 weeks, 3 weeks hence, and they get in their car and it's a dead battery, or, you know, it's broke down, well, then they don't show, and, you know, now we've lost them, and now they're in the ER. And so there are some things I think that we could really move towards. I'd like to point out one other thing. I think we should work with our community colleges and even our high schools to foster a culture of healthcare workers of the future. Community colleges are one of the best places where family physicians come from, because they come from the working class people that will return to these areas. We can't keep like having, I'm not an ophthalmologist, we can't have ophthalmologists' daughters and sons going into medical school and being preferentially selected because they're going to become an ophthalmologist. Now, I've had a lot of eye issues. I love my ophthalmologist, but you know, if we want more family docs, we got to get the car mechanic and sons and daughters going into medicine.
That was a young woman we saw yesterday in Duluth, or the
Yeah.
day before, same exact thing, and just wants to do that. General practitioner into it, wants to return, using the system to help with some of the payments, student loan payments.
Right.
Keep them there.
And having that access so that we can pull down some of that student loan debt,
Yeah.
you know, that's very expensive. So I think I'll stop there.
Great.
I'm Ferry. I work with the College of Pharmacy, the community pharmacies, and also the health system pharmacists. The Hughes College is number 2 in the country, so we're proud of that. But I won't add too much of what Tim said, other than to kind of give the perspective. When I look at healthcare policy, it's, you know, the practice, the services being provided, and then of course the transaction that comes along with that. And somewhere in between is a lot of the policy. I would note that somewhere between 30 and 40% of the population's insurance is government insurance. And so it does start with Medicaid and Medicare, and it really flows from there. Everything from the rebates that are going on in terms of some of the issues that you've heard here are transparency issues. And I think in order to have a fair playing field, at least for pharmacists and other providers, you certainly need to have a fair playing field, and the only way to get to that is transparency. There's some real good work being done by the Senate Committee on Affordability and Accessibility, so I'd look at some of the work that's already being done.
This issue on transparency and debate, just to be clear, both Jeff and I are in agreement on this.
Yeah.
There's no difference there. And we get some pushback because all of us know when you start getting transparency, we'll really start to figure out who's paying for what, those things. And some of it's not always out of malice just for profit. Some of it is understanding what is supplementing those Medicare or those rates that aren't adequate to pay for the services that you need. But I think we'll never get this fixed without that, so I hear you.
Totally agree with that. And so, you know, there's some issues like pharmacy reimbursement are right in front of us because of the CMS outpatient drug rules, some other things states out of compliance on. But, you know, we're trying to be a part of the solution. And one of the things in greater Minnesota is access, of course. And so when networks are closed, when independent community pharmacists can't even negotiate a contract, much less see it before they sign it. You know, some of these issues that Tim talked about are very important, but they're important to the patient because they're interfering between the patient, pharmacist, patient provider, patient relationship, and that has to be paramount in anything that we're doing. And so you also have to look at those issues. The one other thing I would say is there are some nuances in Minnesota law that do present hurdles. For instance, we can do vaccinations, but we can't do long-term injections on Vivitrol. You know, those are the type of things where adherence, there's some great work being done with psychiatrists in teams, whether it's an ACT team, which is really focused, or broadly on adherence. And so a pharmacist can go out to a car sometimes, or to a house, or what have you, and be that kind of healthcare worker that can provide that adherence work. So those are some of the things that I think greater Minnesota can be really helped by too, in terms of from pharmacy. Really happy to be here.
I'm Tom Langman, and I'm with Minnesota County Association of County Health Plans. But one of the groups that couldn't be here today asked me to just say a few words, and that's the issue of mental health. Sunville Valley and Sioux Trails Community Health Mental Health Centers both couldn't be here because they don't have extra clinicians available since they're booked months in advance. What I just handed you, and for the folks listening, I just distributed a map that shows by county in Minnesota where there are adequate numbers of psychiatrists based on national guidelines, child and adolescent psychiatrists. And by national guidelines of Minnesota's 87 counties, there's one county in the state that meets the national standard, and that's Olmsted County. Every other county is either no child and adolescent psychiatrists, which is the majority of the counties. A few have a high shortage and a few have a severe shortage. And there's multiple sort of outcomes of that, of Minnesota's mental health system, which is really a problem. We have among the lowest psych beds in the country for mental health. We don't like to say this, I shouldn't say it out loud because people like to throw things at me, but you have a better chance and you'll get better care in Mississippi if you're mentally ill, either on a public program or a private insurance, than you will in Minnesota. Because here you're gonna be warehoused in the ER for day after day after day, waiting for a bed. And just to wrap up, what this map shows is that there just aren't enough psychiatrists. And that means problems in terms of access. Now, we could fund a couple of additional residencies at the U for about $100 grand a year. And so if you did that for a period of years, we could help address this. But there's, you know, the pipeline is certainly have to go upstream.
If I go back to this question too, because just the vacancies at the VA, to fill those, we need to hire every single graduate this year from every single institution, and we would still be short, just in the VA, and then all the rest of this would be separate.
So we have to go upstream and create more of these rather than just trying to figure out how do you steal one from a community clinic or from a hospital or from the VA and try and, you know, get into a bidding war. We just need more of them. And to just tag on to one comment, Dr. Stelter, just to differ a little bit. Telehealth and telemedicine can help in psychiatry, but I work with Ferry, which is the state's largest provider of child and adolescent mental health services. There aren't enough psychiatrists back at the base to serve everybody. Initially, a few years ago, we thought, well, if we just do telehealth, then everybody outstate can just talk to someone in the Twin Cities. The assumption was that there's lots of psychiatrists in the Twin Cities sitting around with nothing to do and are waiting for the phone to ring. That's not true. So the queues that people are in the metro to see a psychiatrist of waiting 2 or 3 or 4 months, there are similar, not equivalent, but similar queues of people in rural waiting to get online with with someone via telehealth. So telehealth is, but I don't want to say it, telehealth is tremendously valuable in a host of settings beyond mental health, but we need more clinicians.
And that has the dual problem of you also need broadband.
Yeah.
Which is another issue to tackle, but thank you. And I think all of us, this is the preaching to the choir, you know this, these are complex issues. They involve many societal issues that come together. We come to, I hope in this country, a belief that it's morally the right thing to do to try to provide the best care to people. It's economically the best thing to do to keep people healthy, working, living in their homes, rather than having to try and figure out how to pay at the end. There's no easy solution, but there are solutions. We're committed to listening. I appreciate, and I think I'm never too far from this because of the federal work on this, Medicare and Medicaid, strengthening, and then I would branch one step further, TRICARE and VA as the other. You have that in, you've got a pretty big, the entire swath of underpinning the entire system. So Minnesota can't do it alone, but we certainly, you've already done this, innovated in many ways. There are things, and you're figuring out ways around with all these problems, whether it's looking at new ways to purchase, whether it's, I think, our community clinics that are outstanding, focusing on preventative care, and trying to figure out, if I'm not mistaken, I think this is a statistic that's right, we have, or did have, the most independent community pharmacists other than New Hampshire, maybe, in Minnesota?
At one time.
At one time, not changing.
Not anymore.
Yeah. So, yes, and these are decisions that need to be made. Consolidation and economy of scale have implications for all of us. And the policies that we said, my dog in this fight, if you will, is access to quality, accessible, equitable care that also incentivizes providers to be in all corners of the state. And that is not always an equal proposition. It does involve some hands-on, some adjustments. I certainly think I can make the case to taxpayers that incentivizing those medical students to go into general practitioners and work in a rural setting is worth our tax dollars. You're gonna get it back, and we're gonna get them in their communities, and to try and figure out what we're doing if we're disincentivizing keeping money in the state and community pharmacists that are open to serve you rather than having to drive 40 miles or call in. We should be doing that. This is my take to you is, it feels like we might be at a new place in this discussion, that people are pretty much just fed up with the old talking points, that we've circled our, around the axle on insurance reform now for so long. People are starting to recognize that's one piece of it. The payer is one piece of it. But the two that I'm really focused on are the receiver of care and the deliverers of care. We're spending a lot of our time out here on the payer side of things, if you will, rather than getting back into that piece of it. And it feels like people are ready to have a better discussion. So these help. It helps to hear what's working. It helps to hear ideas. I think, again, the time is right. We're gonna have to tackle this. We're gonna have to have a discussion on the provider tax. We're gonna have a discussion on how do we keep people on Minnesota care? How do we expand options for them? How do we make sure counties are able to do it? I'm glad to have the dentists here, and we certainly didn't tackle it in the ACA, but it was a robust discussion about dental and vision care as being part holistically, and then added on top of that, not as an afterthought, but at the core of this, mental health care as the whole person, which has now exploded onto public consciousness, exploded out there, whether it's suicides, started in the veterans community, but we know that actually the group that's even a little higher than them are farmers and rural folks. All of those things are happening, and when you see there's a correlation between lack of providers, lack of access, to actually following through with that. And all of those things are human tragedies or economic tragedies. And Minnesota's always led on this, so I think we view it. I appreciate good Minnesota style. We got things going well, but we're not gonna settle for just that. We're gonna continue to look to see ways to improve, and you are gonna have to be part of that discussion. So, Dan, thank you.
Thank you. No, echo a lot of this, but the biggest echo of all is the partnership that has to exist here. Because as we moved in and out of both what is state and federal, you have to be able to recognize that this isn't siloed, that you depend on both. And the biggest takeaway for me with this is, look, there's gonna be a lot of energy, hopefully, in the U.S. House of Representatives to take on healthcare, to make healthcare reform go on. My own first principle going into that is a medical principle of doing no harm, first and foremost. Because the last thing I want is to have something that is truly unique, which is greater Minnesota healthcare, rural healthcare, to be viewed as just the same as everywhere else. And that's just not the case. Every comment here highlighted a different way in which we are unique in that way. And that's the perspective I have to take, because my viewpoints, what I'm going to advocate for, can't come out of the people whispering in the ears in Washington, D.C. It has to come from here. That's where you make good policy. That's where I think we have made mistakes in the past, because the bigger influence tends to be the one closer to Washington. We cannot operate that way. My role is to make sure that you are all empowered to do the collaboration that you've talked about today. That the energy is there, the relationships are there. What is not there is the investment. And that investment has to go forward, because I'm someone of the belief that the United States can have the best military in the world, the best agriculture in the world, it can have the best healthcare in the world too. But those two things I just mentioned didn't happen by accident. They happened with heavy investment and collaboration, people working together to make it happen in the first place. And so my role in Washington is to enable the energy that's here and make sure we're not doing any harm, but we're actually making these things better every single day, making that progress I talked about at the beginning. Because I think there's an argument being made in the political sphere right now that we should go backwards. I'm sick of having arguments from 2010, because it's not 2010 anymore. We're living in a different world and reality in 2018 in which the stakes get higher and higher every day for our future. Because this is ultimately, at the end of the day, the future of our way of life. Our economy is dependent on our health. And if you aren't taking that long-term perspective on preventative care just as a principle, if that's not even in the discussion right now, then we're all losing out at the end of the day. But again, echoing the thanks, I've got big shoes to fill, but I'm up for the task and hitting the ground running. And depending on these relationships, because again, either a leader knows what they're talking about, or they know where to turn to, or they don't. And that's all of you. So thank you for starting the relationship here today, and I'm looking forward to it continuing post November 6th.
Carmen, thanks for hosting. Thank you all for taking time out.
Thank you all.
We had an incredibly diverse and collaborative discussion today about the needs of Greater Minnesota as it pertains to rural health care and the idea of public health and preventative care, and how we can make sure that every bit of resources dedicated to health care are having the biggest bang for their buck, so that people's lives ultimately are better by it as well. And what I learned very simply is that in the U.S. House of Representatives, you have to make sure that your first principle is to do no harm, that you are making sure that the healthcare system stays as strong as it is, especially as it relates to Medicaid and Medicare, but that you are working harder than ever to empower the collaboration that's already happening here on the ground in southern Minnesota. That's a relationship that I'm going to continue beyond today, because the most important opinions to me are the people actually doing the work, the practitioners, and that's the discussion we had today. Practitioners doing the work, telling us what's working, and telling us more importantly what the challenges are, so that I know what the heck I'm talking about. There's a very simple philosophy of leadership. It applies to healthcare, it applies to everything. Either a leader knows what they're talking about, or they know where to turn to when they don't. And that's what I got a chance to learn today, is I know who I need to turn to when I have any question about any change in our health policy in the U.S. House of Representatives.
Well, today we had a great discussion here. I was proud to be joined by Dan Feehan, but also proud to be joined by a host of medical providers, ranging from independent pharmacies, dental, to the Minnesota Medical Association, and long-term care facilities. Now is the time, and during these political campaigns, while there's a lot of rhetoric that's going around, this is the opportunity to use them as a platform to talk deeply about the issues. How do we keep our communities safe? How do we use public health? How do we make sure we're taking care and having a workforce that takes care of our parents when they're in long-term care facilities? And how do we deliver the best care in the most cost-efficient manner, making sure people want to get into medicine? So this discussion today was meant to, in a setting amongst different practitioners, to try and get at the heart of what we can do. There was a lot of suggestions on what we can do at the state level, a lot of suggestions at the federal level, of course, Medicare, Medicaid, the VA system, and this partnership, and of course having Dan Feehan here, and the work that I've done in Congress to understand where that crossover is. So the good news is Minnesota has the best health outcomes in the nation. We have almost the highest number of people insured. We have incredible medical institutions, and we have a history and a tradition of partnering together to solve problems. So I'm hopeful on this, and certainly if I'm given the privilege to be the next governor of Minnesota, healthcare is a top priority. Aligning these
assets to serve the people of Minnesota is something that isn't overly partisan. It gets really hyped up this time of year. We wanted to use this as an opportunity to have a little deeper discussion on real solutions. So certainly grateful to the members who are here and any community members tuning in to listen. These decisions are going to impact you. We'd love to hear from you.